Next, I would like to introduce Dr. Benjamin Teply. Dr. Teply is an assistant professor at UNMC, and he is in the Division of Oncology and Hematology. His focus is on urologic oncology. I work with Dr. Teply on a regular basis. He is a vital part of our genitourinary multidisciplinary clinic and also our weekly genitourinary multidisciplinary tumor board. Dr. Teply is going to be speaking today on optimal systemic therapy in oligometastatic prostate cancer. Dr. Teply.
Thank you very much, Dr. Ink. I very much appreciate the opportunity to speak with you today. My objectives, I'd like to talk about, really describe the impact of disease volume and distribution on various systemic therapy efficacies. I'd also like to evaluate the data on treatment efficacy in the context of patient being staged with modern techniques such as PET imaging. And ultimately, I'd like to apply principles on optimal treatment of metastatic disease to specific situations, including PET-only oligometastatic disease. So I'm presenting here the disease states model from the Prostate Cancer Working Group 3, sort of some leading thought leaders that really defined how we think about clinical development in prostate cancer. And so just showing a range of prostate cancer disease states from clinically localized disease to recurrent disease after primary therapy, to metastatic disease, either castrate or non-castrate, to advanced refractory castration-resistant disease. Specifically to discuss some issues regarding systemic therapy with oligometastatic prostate cancer, I'd like to really introduce this by talking about a series of clinical vignettes on either side of this line here that I've drawn between patients with overt clinically metastatic disease and those with non-metastatic disease. So the first vignette or case that I'd like to talk about is somebody I put on sort of the far side here on the clinically metastatic non-castrate, or at least representing somebody that presents with high volume disease. So the case here would be exemplary of a presentation like this. A 61-year-old man presents with lower urinary symptoms and worsening low back pain. A PSA is measured and it's elevated at 32.5. A patient undergoes a targeted prostate biopsy that demonstrates Gleason grade group 5 adenocarcinoma. The patient undergoes staging studies, including a CT of the abdomen and pelvis, which demonstrates numerous sclerotic bone lesions, and a bone scan confirms widespread bone metastases. So the standard of care of treatment of a patient with metastatic prostate cancer is systemic therapy with androgen deprivation therapy, and he proceeds with this. Question is, what additional therapy may be indicated for this patient? There's been a real change in sort of our paradigm on treating metastatic disease over the last 5+ years. We now know that we can do better than standard hormone therapy, and several trials have demonstrated this. I wanted to highlight specifically the CHARTED study. This is a cooperative group study first published in 2015 that tested upfront administration of chemotherapy, specifically with docetaxel times 6 cycles, versus a standard approach of hormone therapy until progression for patients that presented with metastatic disease that are just starting on hormones. Highlighted here, one of the stratification factors that was used in this study. And the authors defined sort of 2 clinical states. One, what they called high volume disease, patients that presented either with visceral metastases, such as lung or liver metastases, which are relatively rare for initial presentation of hormone-sensitive prostate cancer, or a high number of bone metastases, which they defined as 4 or greater bone metastases, including 1 outside the axial skeleton. They defined a low volume of metastases, not necessarily oligometastatic disease. It wasn't necessarily the number of metastases, but also the distribution. So either less than 4 bone metastases, a lack of visceral metastases, or node-only disease, regardless of the number of specific nodal metastases. Again, these patients were randomized to either chemotherapy or hormone therapy alone. This was the overall survival long-term benefit for an intervention of 4.5 months of chemotherapy with docetaxel at initiation. This was a markedly positive study, a hazard ratio of 0.61 for deaths, very significantly statistically significant, with a greater than 1 year median overall survival benefit. It's really established that one of the standards of care to consider in a patient presenting with metastatic disease would be chemotherapy. So the second case I'd like to present is somebody a little closer to this line, somebody that may fit that diagnosis of a low volume metastatic disease. This would maybe be an exemplary case for this. A 75-year-old man is diagnosed with prostate cancer, has a biopsy, and it's Gleason grade group 4. He has staging scans, and in fact, a bone scan is negative for metastases. However, a CT scan shows both regional and non-regional adenopathy. So this qualifies as M1A, stage 4 disease, and the standard of care in that situation is systemic therapy. So again, he proceeds with the treatment with ADT. So how might this case be different than the case I just demonstrated with presenting with high volume disease with multiple bone metastases? So back to the charted study. Would this patient derive the same potential benefit with docetaxel as the first patient we discussed? I mentioned that one of the stratification factors is really the volume of disease. And this is from data published in 2018 of the final long-term survival in this study. On the left is the data for the high volume disease. And what you can see is that the very significant benefit with hazard ratio 0.63, nearly 17-month overall survival benefit for chemotherapy was maintained long-term in the group with high volume of disease. However, what's really notable from this study is for these patients that have low volume disease, again, as defined as less than 4 bone metastases, lack of visceral metastases, so exactly somebody presenting with non-regional adenopathy. In fact, there was not a benefit that could be derived from upfront docetaxel. The hazard ratio, in fact, was greater than 1 at 1.04, and both the control group and the intervention group actually did relatively well long-term. And again, just showing here in the forest plot, the remarkable differences just from a clinically defined volume of disease for this intervention. So I'd argue for this patient, probably not necessarily a great option to proceed with chemotherapy. However, there have been a variety of other studies over the last years of similar design, where patients initiating on hormone therapy for metastatic prostate cancer are administered other options, including several different novel hormonal agents. And I've showed the overall survival outcomes for some of these studies, including with the administration of a androgen synthesis inhibitor called abiraterone, demonstrating a very similar overall survival benefit, or to anti-androgens, enzalutamide and apalutamide, which have very, very similar curves. And so currently, it could be considered the standard of care to consider for a patient with low volume disease to have an additional agent added, especially with consideration for a novel hormonal agent. So how might our management otherwise be different with regard to presentation with volume of disease? This is data from the STAMPEDE study. This study is a platform trial that has multiple arms. It's been ongoing in the UK over the last 1 to 2 decades. A sort of remarkable effort where multiple advances have come from the study. One of the arms in the study, arm H, randomized patients that had de novo metastatic disease to local therapy in addition to their standard systemic therapy. And this was the result from that study for the addition of local radiotherapy to the prostate, divided again by the charted definition of either low or high metastatic burden. And I note that this is a sort of an opposite trend of benefit than we saw with the charted study. Whereas on the right, with patients showing up with the charted defined high volume of disease, in fact, there was no hint of benefit for the addition of radiotherapy to the prostate. However, in those clinically defined low volume of disease, there was a significant overall survival benefit with a hazard ratio of 0.68 for considering radiotherapy to the prostate. And again, this is the forest plot showing just the difference in this intervention with a clinically defined volume of disease. This is something that is a consideration. It is in the NCCN guidelines, which we rarely sort of consider at our institution as well. I think I highlight those because despite the fact that these are the same stage of disease, in fact, our data suggests that the value of our interventions are very different based upon these clinically defined disease volumes. So I'd like then to, as a next sort of piece of data to add to this discussion sort of on either side of this line of metastatic or non-metastatic disease is a case of a patient that has a biochemical recurrence after prior therapy. This would be a very common presentation for a patient we manage with biochemical recurrence. 72-year-old man has a history of prostate cancer. He underwent a history of prostatectomy in the past. He had high-risk features at the time, including Gleason grade group 4 disease, PT3A disease. Subsequently, had a biochemical recurrence in 2016 and underwent salvage radiation therapy. However, unfortunately after this, again had a recurrence with PSA recently rising to as high as 2.0. And if you calculate the doubling time has been 12 months. Based upon this recurrence, the patient undergoes staging studies. A bone scan is negative, a CT scan does not identify any sites of disease, and he's asymptomatic. So what's the optimal treatment here? We know this patient would eventually be fated to develop metastases similar to one of our presentations, either with non-regional adenopathy or even bone metastases. Is there any value to considering early treatment in this patient? We get quite a different answer for the patients with overt metastatic disease versus those with biochemical recurrence. In fact, it's been difficult to even necessarily demonstrate early intervention with ADT would provide a survival advantage. Just presenting some data that's really observational data from a database called the Capture database that looked at registry data of patients that either elected for very early androgen deprivation therapy for biochemical recurrence versus deferred androgen deprivation therapy. In general, what we consider deferred therapy is really just observing these patients that have biochemical recurrence until they have metastases and then treat them along one of the first two paradigms I had discussed, or if patients developed symptoms. And very commonly in these studies, if patients develop a very short PSA doubling time, typically that's defined as less than either 3 or 6 months. And often those patients would be considered for hormone therapy because of the imminent development of metastasis that implies. In this database study, there was not a statistically different, there was not a statistical difference between early versus deferred ADT. So while we, for example, with patients with overt metastatic disease could demonstrate that very aggressive treatments, either with chemotherapy or novel hormonal agents, could demonstrate a survival benefit. And in fact, on the other side of our line, on patients with biochemical recurrence, it's hard to even demonstrate that early systemic therapy is necessarily the right thing of value. And so I've discussed both of these cases on either side of this line as we define with bone scans and CT scans. And in fact, as we've defined this volume of disease, the value of our interventions is quite different. We've added, changed our disease state model now with PET imaging. And so what is this going to do? And in fact, we're going to really have a shift in our clinical states where many of our patients are going to be upstaged to overt metastatic disease with our novel imaging. At our institution, we've been performing Axeman PET scans in this context for biochemical recurrence over the last couple of years. The FDA has now approved multiple PET agents with PSMA, which is even more sensitive. And we'll start being able to do that scan at our institution in the next coming months. And so this one challenge for us will be to sort of appropriately treat our patients with this novel imaging based upon the limitations of the data, where most of our data was established in patients with conventional imaging. So, with this knowledge, we have these novel treatments, these novel diagnostics, including potentially PSMA PET imaging in the near future. I wanted to revisit our case of biochemical recurrence and consider how we may think about this differently. So again, this is a patient that is asymptomatic, relatively indolent doubling time of 12 months, negative conventional imaging. However, we know that if we use our more sensitive scans, we oftentimes can identify the occult sites of metastatic disease. So hypothetically, this patient, in fact, has a PSMA PET, and it demonstrates that they, in fact, have 5 metastases in bone. With that knowledge, how does this really change our management? And certainly, there's not a single correct answer here, but there are certainly different treatment paradigms we could consider for this patient. The first one would be, this patient, has 5 bone metastases that we identified with our PET imaging. It's just a matter of time before they become overt metastases. Should we consider that they have a high volume metastatic disease by the Chardy criterion, in fact, consider for chemohormonal therapy? We could consider, well, we could identify the metastases, maybe we treat them along a low volume metastatic disease setting paradigm with start of the initiation of early ADT, and in fact, consider even a novel hormonal therapy in addition. Or we could sort of ignore the fact that we identified these. These were not identified on standard nuclear medicine bone scans. Based upon our data, we don't necessarily have proof that early initiation of ADT just for the biochemical recurrence with negative conventional imaging is a benefit. And in fact, you could argue to observe a patient like this. And then the last paradigm that I'd like to discuss is an oligometastatic paradigm, and really considering metastasis-directed therapy, which is probably the newest treatment paradigm. We've certainly been doing this in select patients at our institution over the last couple years, and this at times can present a dilemma for optimal systemic therapy. With regard to metastasis-directed therapy, there have now been several clinical trials that have demonstrated this as a proof of principle. In highly select patients, this is appropriate per the NCCN guidelines. I wanted to highlight, really go through one particular clinical study called the STOMP trial about what the possible benefit of a paradigm like this may be. In this STOMP trial, this was metastasis-directed therapy without androgen deprivation therapy, without hormone therapy. Those in this study that were eligible for the study were patients that had prior primary treatment for prostate cancer and developed metastasis that they identified by an older PET imaging, C11 choline, which is not routinely done at our institution. They identified what they defined as oligometastasis here as 1 to 3 asymptomatic metastases that were occult on standard conventional imaging. The intervention in this study, they either observed patients, they did this by following up with them every 3 months, and they repeated a PET and considered possible intervention for either PSA progression or the development of symptoms, or those in the intervention group had either surgery or radiotherapy directed at each of these metastases that were identified. In this study, they identified a relatively novel outcome, which they really defined as ADT-free survival. Well, you can think about this as how long can you spare somebody going on systemic therapy in the situation. What they started ADT for was either symptomatic progression, if there was local progression of metastases, or the development of more than 3 metastases. These were the outcomes from the study. In the yellow bar here, these are the patients that underwent metastasis-directed therapy versus those that had surveillance and started on an ADT for the indications I just mentioned. So what the benefit they demonstrated is that there was a significant benefit in terms of ADT-free survival. Really thinking about that is the patients were spared having to go on systemic therapy and have the side effects and toxicities from hormone therapy for, potentially, on average about 12 months longer. Hazard ratio for starting that was 0.55. Again, you could argue about, the long-term value of that, but you could consider that as, possibly a line of therapy where you spare a patient having to go on additional therapies for potentially another year or longer. And on the right here is biochemical recurrence-free survival. And so in fact, you had freedom from PSA progression, which again is not necessarily a clinically validated endpoint, but for patients that otherwise have low volumes of disease or recurrence, this tends to be the outcome that we can measure. I think some take-home points from this and the other studies that have been performed is that certainly it's feasible to consider metastasis-directed therapy in this situation as an alternative to either considering further observation or immediately going on systemic therapy. However, it certainly didn't answer the question about whether we should be combining any systemic therapy with these metastasis-directed therapy. This is an active area of investigation. Multiple clinical trials are trying to answer this. But I thought I sort of have this flow diagram here as a proposed paradigm about how I often think about these patients. And so, if we have one of these patients that has a really PET-detected metastatic disease, the question is, is this somebody that we could even consider for metastasis-directed therapy? Do they have a, based on sort of the size, number, location of these metastases, is this somebody we could consider for metastasis-directed therapy? And there's not been necessarily a standard definition of what illegal metastasis in terms of number is. Or is this clearly a polymetastatic disease? And in those cases, with the identification of this, it's been my practice to treat these patients as if they have low volume metastatic disease. I think I've not necessarily gone to chemotherapy in the situations, given the limitations of the data, even with low volume overt metastatic disease, but considering, initiation on hormone therapy with a novel hormonal agent certainly is an option here. However, what should we consider for these patients that are potentially will have metastasis-directed therapy? I think the next question would, for me, is what types of techniques are going to be used? If in fact ablative techniques, surgical or stereotactic radiotherapy techniques are going to be used, where the rates of local control are going to be high, and there's really no need necessarily for a radiosensitizer in those situations. It's been my practice, or similar to the STOMP trial, to really observe these patients off ADT. If you're treating all the areas that you could identify metastases, I think it's of benefit to observe the PSA after the radiotherapy or surgery is delivered, and really sort of repeat this whole paradigm at the time when there's a progression again. I don't think there's an urgency otherwise to sort of accompany this with hormone therapy or chemotherapy. I think this is different in the situations where conventional radiotherapy would be used. For example, for a patient that has radiographic and nodal local recurrence, where a more standard salvage radiotherapy paradigm would be used. And in those situations, I think that there is good data for radiosensitization and long-term treatment with hormone therapy, and often would consider a patient for hormone therapy, possibly with a novel hormonal agent for a limited time, such as 2 years. So